We're also going to publish a private patient waits list for inpatients. We can't do it for outpatients. There's a quirk in the health reform agreement which is a distinct requirement that there's no private outpatient contribution by the Commonwealth. If an outpatient receives an MBS payment, there's no Commonwealth contribution to that patient. Under this agreement, there obviously is through the MBS. But so we won't be publishing a price list for private outpatients, which in this state are privately referred non-inpatients, I think is the term you use. But we will publish a list of private patient waits. For each DRG, there'll be a wait for private inpatients, and it's different. The deduction is calculated by taking the public wait and deducting off the revenue that would be received for a private patient, and it varies from DRG to DRG. Obviously, some DRGs there's a much bigger deduction because there's a cost like prosthesis costs that come off. So we will publish a private patient wait listing as well, and a methodology we described in our pricing framework. We do have adjustments for ICU stay in some DRGs where ICU is not usual. In some DRGs, ICU is nearly always used, and so you don't need to adjust. It's reflected in the cost weight. But where it's not usual and there's an ICU stay, there will be an adjustment. I'm not, the technical guys can probably talk you through that a lot better than I do, but I can. But there will be an adjustment for ICU, and this tends to negate the effect of large metropolitan hospitals. We often get asked for a loading for large metropolitan hospitals, but we find if we adjust appropriately for ICU utilisation, then the need for that adjustment for large metropolitan hospitals used to be called teaching hospitals, but every hospital is a teaching hospital now, thankfully. We find those large metropolitan hospitals are, that factor is taken into account if we appropriately adjust for ICU utilisation.